My name is Marc Williams. I'm a little bit schizophrenic on my name badge here because I'm listed both at Geisinger and Intermountain. And there is a person in the room actually that looks frighteningly like me. Several people have introduced themselves to him rather than me. Michael, I guess. We haven't met yet, but it is looking here at you, it is a bit disturbing, I must admit. Right. It's the dirty, dark secret that actually I have solved the cloning issue, and it is why I get so much work done. But we're not supposed to show up at the same meetings. At any rate, I am actually the Director of Genomic Medicine at Geisinger Health System, and while my panel comes up, let me just tee up the first panel, which is Clinical Questions to Drive the Enterprise. First of all, I want to also put in my 2 cents related to a point that both Sharon and Reed mentioned, which is the centrality of the patient in all of this. And I'll quote one of my favorite physicians, Dr. Leonard McCoy, "Damn it, Spock, we're talking about human lives." So let's try and keep that in mind. Also, I think there was a very important point that Reed mentioned that we should keep in mind, and I think even though the focus of this meeting is around genetics and genomics, it's important to recognize that we shouldn't be thinking about genetics and genomics information supplanting all other information. We have to really think about it as integrating with all the other information that we have. And if we take the perspective that somehow we throw everything else out because this is the best stuff, it will be, I think, a bad decision in the long run. So let's, even though we're focused on genetics and genomics, let's make sure that we think about this in a broader perspective. So a couple of organizing questions that were provided. And this session is really devoted to the idea of what are the clinical questions that should be driving the use of genetic tests. In other words, when and why should we be ordering tests? Somebody who wrote this said, "There have been no substantial endeavors designed to consider what clinicians and patients need and want." So as having done some of the work, I guess I would feel that it's fairly fair to say that it's not substantial. There have been a few people that have been picking around the edge of this, but we definitely need to have more work. What are the pressing clinical questions? So what are the big priorities? We have to prioritize. We can't do everything, or there are certain things where the cost is not going to be really the most effective use. And moving away from the paradigm that we're currently in, which is applications driving uptake, and again, I think this is very consistent with what Reed was talking about, where we get a new technology and then we find the indications to use it, and it's not limited to genetics and genomics, but rather what is the need that we have and how can we use that to drive the new technology. And we have to do that within the context of the frightening cost information that was presented. So with that, we're just going to go through the list in order here. As Sharon mentioned, Kathie Sutherland was unable to make it because of illness, so we'll start with Holly Peay, Parent Project Muscular Dystrophy.
Thank you. So I am a genetic counselor, and I've done the majority of my work in both Parent Project Muscular Dystrophy is a organization that deals with Duchenne and Becker muscular dystrophy, and I also do work in social science and psychiatry. So looking at why people are interested in genetic testing and psychiatry is a big part of the research that I've been working on. So I'm going to focus primarily on the issues of Duchenne, but I might hit psychiatry a bit. I actually am going to change a little bit what I was going to say, just responding a bit to Reed, which I thought that was a really interesting talk and actually really made me say, oh my gosh, what are we going to do in rare disease? Because clearly in rare disease, we have an issue with this shift from fee for service to performance-based medicine. These are going to be highly burdensome, highly expensive disorders no matter what we do. So what do we do for these families with rare disorders? We can shift the curve a bit, but the question is how much can we shift it and what's going to happen to our families when we get to a system where outcomes are the key. So really I was thinking, what could genetic testing do to help that scenario? What can we do with genetic testing differently that might actually help us be more effective in our our provision of genetics, general health services. So thinking about this through two lenses. So the first is motivation. So genetic testing in dystrophinopathies has been around forever. It's ancient history in terms of genetics, but there are still lots of issues. So access is a major issue. We still have, in our registry, we have about 20% of our families who report that they do not have access to genetic testing in the way that they hope. Genetic testing is used for diagnosis. I mean, this is very basic. We're talking about the most basic use of genetic testing. The problem in Duchenne is that there are muscle biopsies available as well, which are invasive, and families, of course, would prefer to have genetic testing, but muscle biopsy can do the same thing until you get to carrier testing. So one of the things that's happened that's been interesting is the use and the motivation for genetic testing in Duchenne has changed recently through the interest of clinical trials that are mutation specific. So we've actually had this sort of interesting phenomenon where potential therapeutics are driving a different use of genetic testing than was there before. So we have therapeutics that are specific for taking an out-of-frame deletion and putting it back in frame, so you have something that looks more like the milder form of Becker muscular dystrophy, and also skipping over a stop codon. Those are both things that are in clinical trial right now. And what has happened in our world is that the availability of those clinical trials and those potential therapeutics has actually made it so that more insurers and more families are interested in genetic testing. So we have this kind of interesting backwards phenomenon, which I think is something that will happen more and more often in rare disorders, increasing the applicability of genetic testing. An interesting thing that we are dealing with as well is that we have new cardiac recommendations for carriers. So we have now, again, more of a medical basis for looking at genetic testing and having genetic testing paid for, because now these carrier women there are published care recommendations that say they need to be having cardiac screening. So we have matured enough that now genetic testing is not just for diagnosis. Genetic testing is actually informing care in a very different way, which I think is really good news for that curve and getting these rare disorders to actually fit better under this shift away from fee-for-service. Another interesting thing that's happening, and this is, again, I think Duchenne is a model, but it's happening in all different disorders. These single gene disorders, of course, there are lots of other genetic variants that affect the outcome in these disorders. And we have, again, clinical trials driving this in our community where we, for example, there is a SNP in the osteopontin gene, and that SNP seems to be predicting quite a bit of variability in these boys walking. And the walking is used as our primary clinical outcome in the clinical trials. How long they stay on their feet, how long they walk, how quickly they can walk. And there are other genes that are predicting these boys' ability to maintain walking. So, again, we have a situation where we're looking at a potential improvement through genetics in identifying the natural history for these boys and potentially then having treatments that are more effective for subsets of boys. So, again, making the care that we can offer them more effective with limited resource. Now, of course, there are, as a genetic counselor especially, quite a lot of ethical challenges related to that kind of use of genetics, because this is new data. So if we start giving that data back to families about these other SNPs and variants that are affecting their boys' prognosis, for quite a bit of time, and probably for a very long time, that data will be subject to a lot of questions. And it's the question we're really dealing with in our small communities. When do we start presenting this data back to families? When do we start talking to them more about genotype-phenotype correlation and the variants and how the variants are affecting their prognosis, especially given that now we don't know what to do in terms of their treatment. We don't know how to treat them differently. So in our community, those are kind of the cutting-edge genetic testing issues. I think I'm done.
You're right about that, yeah.
Okay. So I will love to talk about psychiatry a bit if we have a little bit of time with the group later. But I think this, it is, I was getting really nervous when I was listening to Reed talk, and I thought, actually, we are to the point where we're moving in the right direction with genetic testing. It really is informing this discussion. So hopefully this will be a model that can apply to many other rare disorders.
Yeah, given the busyness of the day, I'm sure we'll need more of the psychiatric stuff later in the afternoon. So, next is Norm Kahn, who is the Executive Director of the Council of Medical Specialty Societies.
Thanks, Mark. And thank you all for inviting me here. I'm going to share from a perspective of the social contract between the profession and society. And I'm going to do that with three particular foci: at the point of care, where the clinician is with the patient, and then the context of that care from a societal perspective, and the context of that care from the pressures that are on the physicians and other clinicians in that social contract. And the questions that our panel was challenged with were clinical questions driving the use of genetic tests, development strategies, pressing clinical concerns. So let's start the first of three contexts, and that is when the clinician is with the patient. This is where, quote, personalized medicine really has so much promise. And let's remind ourselves that in evidence-based medicine, the highest level of evidence is not a meta-analysis of the world's randomized, double-blind, placebo-controlled trials. The highest level of evidence is an N of 1 study, and that's what works with this particular patient. So the question then comes up, is this test that I'm about to order with this patient, or is this test that this patient has demanded that I order or asked that I order, or worse, has come in with the results of, really going to help me improve this patient's health? And if not, because a lot of times the answer is no, if not, then is the test going to help me improve the health of the patient's family? And the second question that comes up is, particularly in that situation where the patient's bringing in the test result, is am I prepared to deal effectively, efficiently, and ethically with the knowledge that I and my patient will gain from the result of this test? Those are the clinical questions that really sit there at the point of care. And not all tests answer that question. And when the tests are done, the questions often remain. So let's look at the next context, and that is society prepared for the results of this test? Not just is the patient prepared, or the family prepared, or the clinician prepared, but is society prepared? Well, society needs tests with high predictive value. It's not particularly valuable in the healthcare delivery system for the patient to bring in a $1,000 sequenced genome. That's not a test with high predictive value for the patient, for the family, or for society. Society needs health professionals who are educated and prepared to help patients and families interpret genetic tests. Now, like Reed, I had the privilege of sitting on one of the Secretary's advisory committees. In my case, it was heritable diseases in infants and children. And one of the issues for the education subcommittee was, are the professionals educated and prepared to help interpret the tests? And I would share with you that that question is every bit as valid today as it was 5 or 6 years ago. Society needs to protect patients from unintended negative social or legal consequences of the test results, and that links immediately to, now this is not a political statement here, just a professional statement, and that is society needs universal health care coverage and access to be prepared to deal with the results of genetic tests. Those two go together. If we had universal access and coverage, then the question would be less critical about the negative unintended social and legal consequences of the test. So that's a societal perspective. And then let's finish with the clinician's perspective. And we started with the patient and family. We now move to society context. Let's move to the clinician's context. Right now, the priority of the specialty societies as a group, I'm in the umbrella organization. Our priority is to facilitate a culture of performance improvement in practice. That's a challenge. If you look at the basis of performance improvement, you have to have evidence-based, nationally endorsed performance measures. If you go to the National Quality Forum's website, that's the group that endorses performance measures. They're produced by NCQA, which works really for the employers, and for the Physicians Consortium for Performance Improvement. Then endorsed through the funnel to the National Quality Forum. You all know what if you go and look for genetic performance measures, you know what's on there? Anybody done that? Well, there is a section on prenatal care. And here are the two performance measures in prenatal care: anti-D immune globulin and screening for HIV. Those are the performance measures in prenatal care. You know what they are in oncology? There aren't any. So physicians need good performance measures. We have performance improvement continuing education. We have to do maintenance of certification. We have part 4 of maintenance of certification where we have to assess our practices based on our performance. We need those performance measures. We're all going to be subject to maintenance of licensure. And the final thing that I'll say is those performance measures are now beginning to fall out really into 3 categories. The first and most, in some ways, important, and Reed referenced this in his remarks, are outcomes measures, patient outcomes measures. How well do the patients actually do? Most of what we have are process measures, and in some cases the process measures are pretty closely correlated with outcomes measures. Best example I can think of right now is hemoglobin A1C in diabetes. That's a process measure, but it's pretty clearly linked to outcomes. But the new one that's coming are outcome measures that are based on patient goals. And those measures really occur in chronic illness, or particularly in degenerative illness, where patient goals become much more important than patient outcomes.
Thanks, Norm. That was excellent. I would just make one minor correction. I believe, at least according to one of our prior chief executives, that it should be "is the professionals educated." So just to clarify that. Not to be political or anything. Last panelist to talk is Steve Gutman, who has had quite a varied career and currently is with the Blue Cross Blue Shield Technology Evaluation Center.
Yes, good morning. Well, I'm a pathologist, so talking without slides is sort of like talking without clothes. And I picked up on whoever wrote what clinicians need and want. I'm not sure that they actually always know what they need and want. What they need is a stronger base of knowledge that's not actually in any way related to genomics or genetics. I think that we have generations of physicians who've trained and are training who don't know the difference between analytical and clinical validity, who don't know the difference between analytical and clinical sensitivity and specificity, and who don't realize that by their own selection of who they test, they'll affect the predictive value of a positive and negative result. So what they need is more knowledge, and actually plain vanilla knowledge about lab tests. What they need and want is time. That personalized medicine makes the conversation between the patient and the physician more complex. And what they don't have is much time. They have 15 minutes, they have 20 minutes, they have to examine the patient, they have to hear what the patient says, they have to understand what the patient means about what they said, and then they have to superimpose that with some complex, maybe nuanced test that requires informed discussion that they may not have time for. And then what they want, and it's been alluded to, is they want, if not hope, they want honest answers, and certainly not hype. They want the plain, straight facts about tests that they're addressing, and they actually want to know what kind of difference has already been alluded to the test makes. And in particular, my experience, and it's long and rich in a variety of settings, is they want tests that will reduce uncertainty. And to the extent that there's information that gives them some sense, even if the test isn't needed, if it reduces uncertainty, they're likely to like that test. I saw a lot of tests at FDA that I didn't think were needed, and I was surprised at the great enthusiasm for the test because it reduced uncertainty.
Thank you. We're now going to open up this panel to brief speeches disguised as questions and comments. So if those of you who are interested would move to one of the two microphones, we'll be able to facilitate that. While you're making your move, I'm going to take moderator's prerogative and just to put a question to the panel. In Holly's talk, she mentioned about the issue of getting testing to confirm a diagnosis. And one of the interesting things to me is that we're taught in medical school that, you know, the diagnosis, a specific diagnosis, is really the key in terms of developing treatment plans. Yet, it's in the actual practice relating to genetics, there's a lot of pushback sometimes relating to getting genetic diagnostic testing done, either from a reimbursement perspective or from other people saying, well, geez, even if you make the diagnosis, there's nothing you can do about it. So I'm interested in the perspective of the panel and perhaps the larger group about it, you know, how could we characterize the value of making a specific diagnosis, even if it's the specific diagnosis of a disease that doesn't have any currently available treatments?
So, you know, I think we have the very traditional answer to that, which is that it matters a lot to the families in terms of their well-being. They want a diagnosis, the majority of them. In Duchenne and Becker muscular dystrophy, there actually is a treatment. It's not a very good one, but they're corticosteroids, which do help the boys, and there is more data that early treatment with corticosteroids actually helps these boys. You also have very particular physical therapies that you do and do not do with these boys. So we actually do have a somewhat, you know, we can say there is something you do differently. What payers tend to want to hear is that there's carrier testing and you can then do prenatal testing. I mean, that is where the dollars come in, is the ability, and you know, that's not a very politically correct thing, but that's the truth. Again, you know, I think our world is changing a bit because of the fact that there are these mutation-specific therapies. So we have a bit of a different framework than we used to for being able to come forward and say that genetic testing actually is beneficial in terms of a treatment plan.
Yeah. You know, your question reminds me of a meeting at the National Coalition for Health Professional Education and Genetics that happened about 10 years ago. And this is a memory that's just burned into me. There was a young woman there who was a professional. I don't remember if she was an attorney or not. And her family had a history of Huntington's, and she made the informed decision to get tested for Huntington's before she was symptomatic and found out that she was positive. And a few years went by and she was just very early in beginning to have symptoms. And with one exception, she never regretted that decision. But this is a very informed patient who was prepared for the results one way or the other. And saw many potential positives in having the information to a disease that she could do nothing about. The one unintended consequence, however, was that when she changed jobs, she was uninsurable, and that was a huge issue for her that she was really not completely prepared for. So. I guess the bottom line here is that if there is a genetic test for something that you can't really do something about, it's really a challenge to be well enough prepared to determine whether or not that test should be done. And this is an area in which, oversimplifying the issue as a group, I've heard some interesting debates between the genetic counselor community and the primary care physician community, for example, about the difference between if you've got a test that can provide information, that information in and of itself is good, versus the anticipatory guidance that's the model in much of primary care, in which you have a conversation with someone about whether or not the information really is good.
Thank you, and very nice presentations, and I really like the format that Sharon's using today. Ann Cashin, University of Tennessee, as well as NIH. I'm particularly interested in seeing our clinical testing move from the research setting to the clinical setting, and you have talked a little bit about that, because right now the question is, when do we provide the results to the patients themselves or their families? And what I've seen right now, and I'd like for people to expand on this, is that with oncology, which is on the leading edge of this, I am seeing our patients who have cancer have their tumors genotyped, and then their treatment plan is individualized based on the genotyping of the tumor, and can also be individualized based on their own germline genotyping. So I'm seeing that make a difference clinically to the patient, because they are able to then make decisions based on what drugs are going to actually provide them assistance or not. So as you gave the Duchenne's example, you know, I do tend toward let's give the patient that information, but as a researcher, I'm very worried about that as CLIA certified, and you know, what is that? And I'm just kind of interested in the balance that you see, because in oncology, that balance is not definite either. So, go ahead, or anybody.
Yeah, well, I as not as a provider, not as a regulator, not as someone involved in evidence-based medicine, but as a patient, I believe in honesty. So I think that when you have a product that is still growing up, that's still research, it's okay to offer it to patients. In fact, I think it's a great idea to offer it to patients, but it needs to be offered honestly in the context of what's known about it and the fact that it is a research test. And hopefully it's offered in a way that you actually are accumulating data, so it won't be a research test, it'll be a real test. So I actually believe that there's some value to the process, the cycle in which you go through regulation, in which you go through reimbursement decision-making. And I'm not sure you need to deny anybody a test at any stage. What you need to do is offer it honestly.
Well, sometimes it's more interesting in a situation like this if there's some controversy on the panel, and I'll accept Steve's challenge and suggest that that honesty would not be the bottom line guide for me in the answer to your particular question. It's again back to that information, that question about is information which is truth and which is reality, is that always good and is that always beneficial? In a setting in which the patients, families, and the clinical providers that have an ongoing relationship with the patient and the family had access to all of the information and all of the emotional support that was necessary to deal with the information, and the societal context would protect the patient and the family from unintended consequences of the information, then I would probably agree. But I don't think that's our current reality. And the real bottom line is that the patient-clinician interface is not prepared for the information. That if the patient has the, quote, honest or truth or real information, and they take it in fear and anxiety to their clinician, and the clinician isn't prepared to deal with that information, that only magnifies that particular anxiety. So in theory, yes. In practice, in reality, not right now.
So I'm going to split the difference here. So I think that I think you said too high a bar, Norman, because I'm not sure that's possible for talking. If we're moving away from sort of these the kind of old school and moving into the whole genome sequencing and whole exome sequencing, you have the issue of secondary findings that's never going to go away. I mean, for the foreseeable future, we will not be able to predict what we're going to know next year. And that's a major issue with counseling and education for families. And, you know, moving away, there's a lot of literature on moving away from clinical utility and talking more about personal utility. So what is each person's personal utility for this data? That's a data resource that will continue to change over time. And that's a huge challenge. I mean, that's a challenge for genetics professionals, forget primary care. So I think that there's still a purpose for that data, and there's a lot of interesting research going on about why people want that data and what they're doing with it. But I think, you know, really we don't have an answer. We can't say we can give people all the information they need, and we can't say that we'll ever be able to give people all the information they need, but it may still be information that's helpful for people in terms of actionable medical issues and their own intellectual peace of mind.
You know, there's one other thing I'd add, and Reed mentioned this, and I might, you know, entice him to even respond to it if he thinks it's worth a response. But the idea of the coverage with evidence development, and this is a different role for payers because payers traditionally have not been charged with covering the research enterprise. Although there's an interesting example that particularly I think related to the rare disease issue is very salient, which is the Children's Oncology Group, where the oncologists in pediatrics said, you know, none of us are ever going to have enough patients to be able to learn anything unless we work together. And so very early on developed a situation nationally where all the data were accumulated nationally, the protocols were developed nationally, and basically every child with cancer became a clinical trial patient in the course of usual care, and payers paid for that, even though they perhaps didn't necessarily know that they were funding research at an explicit level. It seems to me that this is a model that is at least possible to address some of the issues related to rare genetic disease. But I think that there's, now that we're actually putting words on the table relating to evidence with, coverage with evidence development, how that would actually be operationalized and how we would get everybody to play, I think is difficult, but I think it's an intriguing idea. So I just want to put that on the table, and I don't know, Reed, if you want to respond or not, but...
The only reason I'm responding is because you've made it a question of whether it was worth it, and I would insult you if I did. It's like, no, it's not worth responding. But very quickly, very briefly, I think that you've laid out in fact, all I would do is underscore the way you set up the construct of the question. And that ultimately is that at the end of the day, can those who are, because Holly's point, Holly has to be respected in the point that she started out with, which is for those who have a rare disease for which there is no current cure, what happens to those people in the midst of all this dynamic change? And so at the end of the day, how can we ever get enough information to answer that question and make it possible for those boys to get what they need, which a society has to address? So I think the way that you describe it is, can the research and clinical community find the mechanisms to bring this stuff to at least enough scale? Can the people that are involved in the intervention start out with at least a premise that says, we're not trying to rip off the doggone employer community and saying, look, we understand we got to get reimbursed, but this is not a game to rip everybody off. So you don't have to distrust our motives going in. That takes a lot of the pressure off. Then having those organized systems where they're efficient to be able to get at that information, and now you can actually have a conversation with employers, recognizing that they're scared to death around how to do it, but finding ways of doing it cost effectively. And I think you laid out the premise in your question formulation.
Lawrence.
Thank you, Lawrence Greilack. Thanks for inviting me, Sharon, and others to be here. I'm listed as being self-employed. I'm self-employed as an independent regulatory consultant, but I do have a background in clinical practice, in fact, in neonatal perinatal medicine, where in the old days I was there to give the parents the bad news, and then what do we do from there in terms of, yeah, in terms of is there more testing to be done, or you know, why metamorphosis does not take place in terms of, you know, genetic abnormalities, and, you know, what treatments can be availed. And then I moved into the regulatory world for the last 10 years. I'm not trying to cement my CV, although I am looking for work. But, right, honesty, Steve. Yeah. So the point I'm going to talk about here is standard of care, and all the speakers have talked about this. When you're in clinical practice, or at least when I was, standard of care was what you were taught during your residency and fellowship, and what some bright speaker at a conference said based on a single clinical trial for a product that had not been approved. And as we all know, half of those products or more were ineffective and had a lot of adverse effects. Then when I got to the FDA, it was a big shock, because you know, the basis for approval was quite stringent, and standard of care meant something totally different. And the dilemma that exists in terms of doing the research that we're all talking about is, how do we deal with the standard of care and trying to develop new diagnostics or new therapies, because there's an ethical dilemma. If standard of care is established within a therapeutic and even within a patient community, how do you compare the new product against, you know, that perceived standard of care, even though the standard of care that exists has no good research basis? And that is often the crux of the dilemma that we're facing in trying to do research and then trying to come up with meaningful clinical trial results. On the other hand, you can't use placebo in many cases because practitioners or even patients or parents of patients will not allow that to take place. So we're faced with that critical issue in trying to support approval of new products. So I'll just close by saying there have been some studies done on the half-life of standard of care, and it was astoundingly long when studies were done. So I think we're facing, and based on what Reed and others were saying, I think we're facing that dilemma and trying to change the standard of care, but having really the basis to do that based on good research, and then to assure the practitioners, the patients, and the insurers to support that. So I'll end here, although I'd like to talk more and see what other response there is from, you know, the staff here.
Yeah, I'll respond if I may, and I appreciate the point that you made about in many situations, particularly with children, where you're really constrained to do placebo-controlled trials. It's possible that the new focus on comparative effectiveness research will really help in this particular area. The Patient-Centered Outcomes Research Institute is now up and running. They're holding meetings around the country. They're getting their agenda together. So this may be a situation in which standard of care could be compared and contrasted in research trials against some new opportunity instead of placebo. And we may be able to get to the information that way.
Thank you for your response.
I think we have time for one more question. So, Lisa.
Thank you. I'm so glad that I traveled all the way half across the country to be here in person today, because nothing like having personal interaction. And Sharon, we have to applaud you because the Alliance is always on cutting edge with the seminars. So my first comment is in terms of what we gain from genetic testing, I think that that's been proven in Mendelian diseases over and over again. I think Duchenne is leading the field for having very specific genotypic information that is now, in fact, going into clinical trials. I think we're going to see that with lots of other diseases, rare or not so rare. And I think defining the exact mutation to take it to an exact target, whether it be an orphan disease or not, I think is going to become the norm. The second thing is that whether or not we're ready for this explosion between genomic medicine and clinical medicine to happen, it is, in fact, happening. There's not a day that you don't open Genome Web that you see that a new personalized medicine lab has been launched, whether it's at a university or at a big company such as Illumina, who's now offering CLIA testing. And so this will be the challenge now of agencies like the College of Medical Genetics and certainly the FDA to know that this is coming forward, and we have to catch up with it. We do have to develop standards in evidence-based medicine. And I think, I know some grants that we are working on at TGen have in fact put in a very evidence-based arm in whether or not a person going into oncology testing will have actual genetic testing and information as part of the arm of their protocol. So this may be one of the first trials of this. The second thing is that we do need to try to move, as the woman said, oncology, from all of this information into a CLIA-based setting. And so what we're doing in our model, I'm glad I'm around most of the day and I'll talk more about it to anyone who would like to hear about it, is we're taking our genomic sequencing information from the research lab, going to the CLIA lab for actionable targets. The CLIA lab will validate those things that we believe are actionable targets. It's a very huge model because it does involve computational biology. We have an oncology tumor board that's involved, so the CLIA lab process is only one part of it. So we are not giving back all the information to the patients. We're giving back the things that we think that we can help in terms of therapy. These are very challenging times. There are no standards yet for both CLIA as well as ethical and legal standards. And so I just think it's great they're all here talking in the same room today. Thank you.
Thank you. I think we will close this panel. One of the things that we want to do today is to develop some takeaways for next steps, and I'll just summarize that one of the things that I've taken away from our discussion here is that we really desperately need successful demonstrations of a value proposition for genetic medicine. And I think a couple of the examples that have been brought up, which is molecular characterization of tumors to specified treatment, is one that I look at as emerging in the very near future. I think we do have a couple of opportunities in rare disease related to some of the mutation-specific therapies that are either in trials or moving into later phases of clinical development. So that was one. I think that we need to identify where are our wins, where we can really say this is how you can do it, this is how you can develop this innovative technology, deliver the goods, and actually make a bend in the cost curve for this particular entity. The second thing that I'm sure we're going to be getting to as we go through the rest of the discussion today is the idea that we will in fact have low-cost genomic sequencing. And so how does that change the game from a one-off genetic test that maybe costs $4,000 where you can do the whole genome for $1,000? Does that really represent cost savings, or do you develop so much information that has to be tracked down that you actually inject more cost into the system, tracing down all the things that you really don't need to perhaps be paying attention to because we don't know what exactly to do with it. Not to mention the fact that in the last couple of comments we've heard the fact that at the present time whole genome sequencing is not of a clinical quality that you can return the result, that you really have to do the validation. So now we're talking about adding a cost of a whole genome sequencing to a traditional cost of a genetic test, which is not the way to bend the cost curve. So those are my two takeaways from this, and we'll move on.